Hello everybody. Just getting everything set here. Thanks for joining us today. My name is Elliot Robinson. I'm a hand surgeon at OrthoGeorgia, and I'm going to be discussing targeted muscle reinnervation, which is something that may be new to you. It's showing a lot of promise in terms of prosthetic control and treatment of nerve pain in amputees. At the end of the presentation, we'll have a moment for some questions. So you can go ahead and put those in the chat if you'd like. If anybody can't hear me or you're having any kind of issues with the technology, you can put that in the chat as well. Okay, again, my name's Elliot Robinson. I've been at OrthoGeorgia practicing hand surgery for about 10 years now, seeing patients in the Macon and Warner Robins office. I'm a board certified hand surgeon as well as orthopedic surgeon. And I think one of the things that separates OrthoGeorgia from some other hand surgery practices, particularly in the private world, is we do have a large referral population and see a lot of both acute and elective trauma reconstruction through our work at the Atrium Medical Center. Prior to coming to Macon, I was in Charlottesville at the University of Virginia for my hand surgery fellowship, which is also where I did my medical school. And I did my orthopedic surgery residency at Carolina's Medical Center in Charlotte, and did the hand surgery training portion of that with the Ortho Carolina group. And really the Ortho Carolina physicians got me interested in this topic. Some good mentors and good friends are very active in this field. Dr. Glenn Gaston and Brian Loeffler have pioneered certain procedures and have put together really an excellent multidisciplinary clinic for patients with upper limb amputations. They actually see lower limb patients as well. And I was able to join them. They were gracious enough to host me, and this was facilitated by the Hanger Clinic, who works closely with them. And I saw the way the Ortho Carolina Reconstructive Center works, and the key thing is really bringing together the different disciplines that make patient care happen. You've got the surgeons, you've got the prosthetist, and you've got therapists all together. That really facilitates communication between the subspecialists, helps outside the box thinking, and really it creates a great just logistical benefit for the patient. And after seeing that, I really think that's the best model for treating these patients, and that's what I'm putting together here at OrthoGeorgia. What I came away from that visit was really you need some critical ingredients to do this properly. First of all, you need a volume of patients that need your services so you can do the best for them. And so we've got a level 1 trauma center here. You also need to have a prosthetist who is interested and trained in dealing with the upper limb. It's a little bit different than the lower limb and a lot more myoelectric work. And you need to have good therapy. And we're really blessed to have great therapists here at OrthoGeorgia, including Diana Williams, who's been with us for many years and happens to find this particular project interesting. So what I'd like to do is make this case-based. Really, the first candidate who came to my office, I felt that really needed this procedure was a 23-year-old. He had had a transhumeral amputation 2 years prior to seeing me, and he was referred for treatment of his neuroma pain. He had two previous unsuccessful attempts at dealing with this pain, essentially resecting his neuroma and burying it in muscle, trying to get him to be able to wear his prosthesis. But he came to me with a lot of pain. Any kind of pressure on that nerve was very uncomfortable, and so he really wasn't wearing his prosthetic all that much. So taking a step back, we should take a few minutes to describe myoelectric prosthetic limbs. You all may be well familiar with them, but the idea is that you can control these voluntarily by firing a muscle. That signal gets picked up by an EMG surface electrode on the device, and that'll be translated to motion by activating the electric motor on the device. Some of the pros are that you have much more control in many cases than a body-powered prosthetic. You can generate more power. You're certainly going to have less fatigue. It can be a little bit more intuitive. There are some cons. They're still quite expensive in most cases. There's issues with durability, battery life, weight, fit, etc. And that's not really what we'll be talking about today. But ultimately, you're limited in the functions of your prosthetic by the number of individually controlled and sensed muscle groups that you can use to activate the limb. So again, the prosthetic limb is only as good as the ability to wear it and to control it. And so that can be limited by many things, and one of those things is pain. So most amputees do have pain. That can come from neuroma pain, which is often sort of mechanically mediated and stimulated. There can be more generalized phantom limb sensations, residual limb pain. And we know that many of these, essentially the majority of amputees have some component of this, and that can lead to decreased function, depression, need for medical management, etc. And there's been a transition from more passive treatment of those issues. Again, just try to mask it with medicine, or just try to bury the nerve somewhere where it's less symptomatic, and become more active about managing these nerves. And the mantra is to give that nerve something, somewhere to go and something to do. And enter targeted muscle reinnervation. What is this? It's essentially a nerve transfer. The idea is taking a severed nerve from the amputation and transferring it into an available sort of musculoskeletal unit. So you're severing the motor branch going into that muscle and plugging in the amputated nerve. That nerve can now control that muscle, and that muscle can act as an amplifier for the EMG detection. All of this started, there's kind of an origin story. Jesse Sullivan was a patient who lost both of his arms from an electrical accident, essentially. So he had basically shoulder disarticulations bilaterally, so sort of an enormous functional problem here. So his doctors at Northwestern pioneered targeted muscle reinnervation to try to get more signals, to get more function out of his prosthetic. And so you can see in this image, they took some of the amputated nerves, swung them around, and innervated separate parts of the pectoralis muscle. And this increased the number of voluntarily controlled motor units to get more different signals to power more functions in the device. I would just have a static picture of this gentleman. I wish I had a video to show you just the incredible control that he has. He can basically flex different parts of his pec to make his elbow flex and extend, to move his wrist, and to move his fingers. And so, going back to the example of my patient, in a transhumeral amputation, you've got the ability to power elbow flexion. This is pretty easy to do. You just think of moving your elbow, you flex your biceps, the prosthetic picks up that signal and powers the motor to flex the elbow. And the same thing with activating your triceps and getting elbow extension. But after targeted muscle reinnervation, you still have those biceps and triceps signals. But if you would transfer the median nerve, the radial nerve, and the ulnar nerve, now you have 2 signals that become 5 signals, so greatly enhancing the potential signals to power that prosthetic device. So a lot of the doctors treating these early TMR patients were really excited about how many more functions they were getting out of these prosthetics, and that was helping their patients. The patients were excited about that, but they were noticing there was this pleasant side effect, that the pain just wasn't as bad as it used to be. The story goes that the doctor said, "Yeah, that's great. Well, look how good your prosthetic is moving." And they're like, "Yeah, doc, my pain is better." And eventually, the surgeons listened and found that this was really an excellent benefit that they could offer their patients. And now management of neuroma really is one of the primary indications for using targeted muscle reinnervation. So as you may know, a neuroma is a disorganized bundle of axons, the nerve cells. So basically any time a nerve is cut, you're going to get a neuroma. Sometimes they're symptomatic, sometimes less so, but they always form this sort of enlarged stump of nerve cells. And what we found is that burying this in muscle is just not usually as satisfactory as we want it to be. And so we want to give that nerve somewhere to go and something to do. And in fact, the literature bears this out. Targeted muscle reinnervation does improve pain in upper extremity amputees. There was a series out of Northwestern Hospital that showed that the vast majority of these patients had complete relief of neuroma pain. I do want to highlight the primary author on that paper was a friend of mine in undergrad. He went on to plastic surgery training, and it's just been fantastic to see him on the podium presenting at national meetings. Just kind of another inspiration for me to take on this project. Other universities have showed similar improvement in pain relief. They've also shown that this can improve lower extremity function. Of course, the lower limb amputees, amputations is just incredibly high volume, something like 200,000 below knee amputations are performed in the U.S. every year. And it has been shown that if you add in targeted muscle reinnervation, that it decreases pain and does increase ambulation, so you can make a big difference in people's function. I do want to introduce another concept, another alphabet soup, if you will. RPNI is something you might hear about. This is regenerative peripheral nerve interface. And essentially what you're trying to do is cover these nerve ends in muscle that becomes active instead of just passive. So you perform an intraneural dissection. You're going to take a bigger nerve, make it into much smaller nerve fascicles. You're basically getting more area for this interface between the nerve and a muscle. The idea is that you're going to take a free muscle graft, and the benefit of that is that it's denervated, okay? So it's actually looking for something. It's looking for a nerve. The nerve's looking for something to do, and so you do get this interface where the nerve will grow into a denervated muscle. And these small muscle grafts, if you do it right, they essentially survive like a skin graft would, where at first they're just getting their nutrition from the extracellular space, and then they get revascularized and survive. And this has some benefits. First of all, there are some scenarios where you just don't have a good muscle to plug into. This is technically easier than targeted muscle reinnervation. The downside is that you're not going to get that same sort of EMG amplifier effect that you get from targeted muscle reinnervation. This does show significant reduction in pain in studies. And there's been I think this is a great indication. Digital neuroma, there's obviously not a lot of muscle in the finger, so you don't have a great target. But there's been a series showing 85% pain improvement in RPNI in the digital neuroma space. So that's very promising, particularly for this sort of notoriously difficult problem. So going back to our case, we've got this 23-year-old. He's got a well-healed wound. He's got good soft tissue coverage. So those aren't really active issues. He just has a very, very strong tunnels over the medial brachium. You tap on this neuroma and it just lights him up. And this is what his MRI looks like. That big white circle is a neuroma. That's probably 4 or 5 times the size of what a nerve should look like. So all signs are pointing to a symptomatic neuroma, and I recommended targeted muscle reinnervation to reduce his pain with prosthetic wear and to give him the option of hopefully increasing his prosthetic function. So the plan was to take his ulnar neuroma and to transfer it to the musculocutaneous nerve branch, the brachialis. So just to orient you, I've got this picture of the upper arm. The biceps has been cut away, and you can see the brachialis below it. That yellow branch coming on top of the brachialis is the musculocutaneous nerve. It fires to both the brachialis deep and the biceps superficially, okay? So that's a great target. So you can plug in to this branch so that the biceps still fires under voluntary control, but now you have a new way of innervating the brachialis musculature through this transferred ulnar nerve. This is what the neuroma looks like. It's a little bit washed out, but if you look close, you can see that this stump is probably, about 4 times the size of the rest of the nerve there, okay? So we excise that back to healthy fascicles. Then I dissect out the musculocutaneous nerve. You can see that nerve coursing from proximal to distal with a branch going up to the biceps and a branch going down to the brachialis distally and deep. See if I can get that. And this is using a nerve stimulator to differentiate between the nerve to the brachialis and to the biceps, okay? So I want to preserve the branch to the biceps, but sever and use the branch to the brachialis. All right. And this is what the reconstruction looked like when I was finished. Again, distally here, you've got the branch to the brachialis, and here you've got the ulnar nerve, neuroma, which has been cut, and then they've been coapted, and there's a collagen wrap to protect that repair. And this patient did great. He had early improvement in his pain. At 5 months, it was at 80%. And when I saw him at further follow-up, he said it was essentially completely resolved. And that has lasted. I saw him at a 2-year follow-up recently. He had no pain at the neuroma site. He had unrestricted use of his prosthesis. He didn't really incorporate a new function into that prosthesis. I'm not exactly sure why. I don't know whether the patient wasn't interested or they weren't really able to train him, or whether the EMG signal wasn't all that great. I don't know if there wasn't funding to alter his prosthetic. And those are all sort of some of the reasons why I think having very close interaction with your prosthetist is great. You can kind of work through that, and you can really kind of maximize things. You get better communication. And so I think that's part of having this multidisciplinary clinic, one of the benefits of that. Interestingly, this patient has come back to see me, and he has developed a new neuroma. Unfortunately for him, this is now, I think, about 5 years out from his injury. It looks like his radial nerve is now pretty symptomatic. He can feel a big mass. He hurts when you push on it. So I've injected him, try to see if I can manage it non-operatively, but I think there's at least a reasonable chance that he's going to want something done, like another targeted muscle reinnervation for him. So I hope I've introduced the topic to you and given you something to think about for some of your patients who you think might benefit from this. I'm excited about offering this to my patients. I think it really offers, opens a whole new world in terms of function and pain relief. And at this point, I'd like to open it up for questions, and I'll be checking out the chat here, see if anybody has any questions. None yet. All right. So, all right. Well, good. Well, if we don't have any more questions, we'll conclude the meeting. If you want to get a hold of me, you can get a hold of our. Should we put up a? Why don't we email everybody? Our work comp coordinators, and then we'll go from there. Okay. All right, everybody. Thanks. Have a great day.